Hello, good afternoon, Dr. Liliana de Lima. Good afternoon, Dr. Tania Pastrana. I'm bringing, and I have the honor to convey the greetings of Dr. Daniel Salaverry, President of the Congress of the Republic of Peru, and Dr. Humberto López Gilela, Congressman of the Republic, author of the 3486 law, which is the law on palliative care in Peru. I'm Luis Hurtado. I'm an internist. I'm the main advisor at the Congress of the Republic. And it is an honor for me to be able to work with many of the decision makers, officers, and people who are engaged both nationally and internationally in palliative care. We have just heard about the experiences, and I will summarize what we are doing or planning to do in Peru. Last week, we were in conversations with the Minister of Health and the Vice Minister, and today, within the audience, we have the participation of officers of the National Ministry, the National Institute of Neurological Diseases, Social Security, and many other institutions, both public and private, like Dr. Maria Berenguel, who's spoken about Colombia. And today, we might say that Peru has a law. We have to join efforts as health professionals. And what I'm conveying today is that we have a commitment from those people who are decision makers in this country. We started to find out that the definitions of palliative care is something that we commonly handled, and we were able to see that the non-oncological patients' needs, and that we did not have the vision to include them. They accounted for 60% of the demand compared to oncological patients who accounted for 40%. We then had to revisit the world literature to do something viable in Peru. So there are different institutions like the National Police, the military, and institutions and private hospitals and national hospitals. They start doing their own efforts, and they developed this in Peru. We knew that the access to palliative care was low, that the need of pediatric care was high, and that our country was facing a demographic transition like in the world. We were observing that this transition and this populational growth, people over 60, with a projection by 2050, required us to have a national policy that will meet this underserved population. We saw that the life expectancy, both for men and women, was increasing. And 1 out of each 4 Latin Americans will be greater than 60 years of age. So we wondered with the other groups of advisors, what does Peru do, and if international experiences are really showing some evidence in Peru. The demographic profile of Peru was clear. We were under a demographic growth. We've even reached 40 million. The aging index was increasing. People depended upon others to be able to work, to function. So the dependency of many of our elderly and the assistance that they were receiving at different care and complexity levels was not the adequate care. The demographic profile was also something here. We needed to see if we were covering the right age group. There were several studies being conducted to see what's going on with chronic oncological and non-oncological patients in high complexity hospitals to see if there was an impact on the cost. We were surprised because 70% of those patients who were kept at the high level of complexity were over 60 years of age. 25% of them required complex healthcare at that hospital. The other patients required support, only required life quality, and required care that could not be given at that level of complexity, but we couldn't let them down. So the system here was not prepared for this. we were even using, and haven't seen other experiences, we were requiring PET scans or mammography to stage 4 patients in their last days of life. And even so, high complexity hospitals were spending these resources, not only of the inputs and the equipment and the drugs, but human resources, which were wasted, who did not know how to communicate this bad news to the family members, who were also engaged in knowing what kind of support these patients needed. Having seen this, we said it's true, we don't have an aging manual. And one of the barriers we found for to have a good palliative care manual or the law is that the political decision makers, those who had to know where we were heading to, they didn't know about palliative care. We were not looking for information that would be of benefit to all of us. We were more focused on the media, and we did not take a look at palliative care as such. We were not paying attention to what the international policies were teaching us. This is why, by handling the different care levels, the strengthening of primary care, the strengthening of household care, favoring oncological and non-oncological patients with different pathologies, this was actually a need to be in the state-of-the-art of palliative care around the world. Now, considering the Latin American experiences, the presence of doctors from Argentina in the palliative care forums, we could see that this is a reality that it's been overlooked, and we needed to bridge this gap. We knew that in Peru, and also the issues related to pediatric patients is very important. In Peru, this is the evolution of different experiences, different stories. Many of our physicians who are here, and some of them have already passed away. It would be just a matter of pride to hear about the passing of this law. And today, this law is a reality. Now, the representatives of the Ministry of Health are here. They have a very clear responsibility to regulate and implement, as we have seen in Panama, this healthcare model. I don't want to mention each one of these names because I can forget about some, and it wouldn't be a nice thing to do, because we treasure the experience that each one of our professionals had: psychologists, therapists, nutritionists, physicians, nurses, this multidisciplinary approach that is needed. This is why the political constitution of Peru, with the spirit of safeguarding the right that we all have to health, and the Universal Declaration of Human Rights, and also our general health law, like a regulation that Peru has, which now makes it mandatory to receive palliative care. In September of year 2017, there is a bill which was introduced, and then we started presenting at the different sessions of the Congress of the Republic. And we had to deal with many of these concepts that we've been hearing all day so far. The fact that we have to unite these three levels, the fact that we have or need ongoing medical education in Peru. There will be 2 master's courses. We've had meetings with the Medical Professional Association, since we need to have experts on this. We have undergraduate courses, we have technology. We were mentioning about the e-medical histories and also the monitoring at home. And the fact that we have to consider transportation. We have a transportation system which is for urgent and non-urgent transportation. But what to do with our chronic patients who oftentimes have to go to their hemodialysis services, but there's a time that they want to spend their last days with their families and to be able to enjoy those moments, and as we have heard, to get them well prepared to their moment of death. This is something that we aspire. A commitment at the level of the President of the Congress, something that will foster this palliative care healthcare model. The commitment of the Congress people who are working with two projects in parallel with integrated networks. The Project 24400 that will be presented at the Health Commission next week, which states it very clearly which are the annexed services in the integrated healthcare networks. What is the impact on costs? Peru's Social Security managed a palliative care program which served to issue the organization and management of palliative care with an impact of 139 million soles per year, strengthening household care and also mechanical ventilation at home. They strengthened multidisciplinary management and the hospital support program on palliative care. What are the experiences in the world? They make us think that with this new law now in Peru, we might have political, economic, social, and health impacts. And to tell the truth, the tool, as we have heard before, is to think and to give an opportunity to strengthen a new healthcare model that will engage palliative care in a consistent manner. The 3846 published in El Peruano newspaper, which was approved by the President of the Republic, is a clear example that in Peru there is political willingness, commitment. That in Peru there's not only commitment on the part of the Congress members and politicians. Today I've been discussing with different past ministers, and we know that we need preventive care here in Peru, and the decision makers who are here won't be there in 10 years' time or 20 years' time, but they have a very serious responsibility to abide by. This is our flagship child. He's a 10-year-old with osteosarcoma. He made Congress members see when he required them to sign the law and to have it ratified by the President of the Republic. He said that this is not the end of palliative care. He had a friend at the Neoplastic Institute which mom was pregnant. She was sleeping in the floor of this institute. They were living 6 hours away from the capital. And this referred to this human part, which sometimes they forget. So afterwards, this bill was signed with the participation of lots of people who were there, and we would have liked to have a larger place to host many more people who were part of this story. And some days ago, we participated with the senators and the deputies in Paraguay, and we explained about this importance of reinforcing palliative care in Peru. Thank you very much.